My name is Michelle Skrzyński, and today, October 29, I will be presenting my case presentation on pelvic inflammatory disease. Typical patient presentation. A 21-year-old female presents to the clinic with nagging lower abdominal pain and a high fever of 103 degrees Fahrenheit. She describes her pain as being crampy and bilateral. Recently, she has noticed a foul-smelling vaginal discharge and has dyspareunia with abnormal uterine bleeding. She acknowledges she has been sexually active with multiple male partners and inconsistent condom use. She also reports a history of chlamydia treated 1 year ago. Pelvic inflammatory disease, or PID, is an infection of the upper female genital tract, including the uterus, fallopian tubes, and ovaries. The bacterial infection ascends from the vagina or cervix, which is essentially a long tube, causing an inflammation of the tubal mucosa. Many types of bacteria can cause PID, but the most common bacterial infections, also known as STIs, are chlamydia, from the bacteria C. trichomatis, and gonorrhea, from the bacteria N. gonorrhoeae. The least common cause of PID involves ascending anaerobic organisms that are associated with bacterial vaginosis and bacteria entering the reproductive tract when the normal barrier created by the cervix is disturbed. This can happen during menstruation, childbirth, miscarriage, or abortion. Even though it is rare, bacteria can also enter the reproductive tract during an insertion of an intrauterine device, a form of long-term birth control. In early studies of PID, N. gonorrhoeae was the most commonly isolated bacteria. The prevalence of PID has been decreasing since 1985. Even though in 2000 there was an estimated of 1.2 million medical visits, the prevalence of gonorrhea has decreased. This does mean that the prevalence of PID has decreased in the last decade, and screening for bacteria C. trichomatis has contributed to this decrease as well. PID has shown to be most frequent in women ages 15 to 25 years. Risk factors for pelvic inflammatory disease, starting with the bubbles from the top left, include sexually active females under the age of 25, having multiple sex partners, having a sex partner who has multiple sex partners, having sex without a condom, having a history of pelvic inflammatory disease or infection by a previous sexually transmitted disease that was not treated, douching regularly, which upsets the natural balance in vaginal flora, or the insertion of an intrauterine device. Other causes of infection include normal or abnormal deliveries, spontaneous or induced abortions, or other surgical procedures that involve inserting instruments into the uterus. These infections are often polymicrobial, meaning the infection is caused by several types of bacteria. Because the female reproductive tract is essentially one long tunnel, an infection can travel up the tract pretty easily. Let us start from the bottom. PID develops when pathologic microbes ascend from an infected cervix to infect the uterus. The infection can move upwards to involve the fallopian tubes and tubo-ovarian region. The infection can also then go out of the fallopian tubes and spread to other adjacent regions such as the pelvis and abdomen. Pelvic inflammatory disease is most problematic when the infection reaches the fallopian tubes. When infection is present, the body responds by sending neutrophils, plasma cells, and lymphocytes towards the problematic bacteria. Even though this response may sound like it will clear the problem, it does not. It actually damages the tubule epithelium, and the tubes then become filled with pus. This leads to scarring of the fallopian tubes. When scar tissue forms to repair the damage, areas with damaged epithelium tend to stick to one another, blocking the tubes. This damage can lead to a number of complications, female infertility being the most common. It can increase the risk of ectopic pregnancy because the scar tissue prevents the fertilized egg from making its way through the fallopian tube to implant in the uterus. PID can also cause chronic pelvic pain. Here we see an image of a normal, healthy female reproductive system in comparison to a reproductive system with PID. Untreated PID might cause scar tissue and painful collection of pus, also known as abscess, to develop in the reproductive tract. You can see why such damage can lead to a number of complications. So now let us go back to our typical patient presentation. A 21-year-old female presents to the clinic with nagging, lower abdominal pain and a high fever of 103 degrees Fahrenheit. She describes her pain as being crampy and bilateral. Recently, she has noticed a foul-smelling vaginal discharge and has dyspareunia with abnormal uterine bleeding. She acknowledges she has been sexually active with multiple male partners and inconsistent condom use, and she also reports a history of chlamydia treated 1 year ago. Key symptoms this patient presents are indicated in pink. Some women will have few or no symptoms of PID. When there are noticeable symptoms, they include pain in the lower abdomen and pelvis, abnormal vaginal discharge that may have an unpleasant odor, tenderness around the ovaries and fallopian tubes, abnormal uterine bleeding, especially during menstrual periods, systemic symptoms such as a fever with a temperature higher than 101 degrees Fahrenheit, sometimes with chills, and dyspareunia, which is a medical term for painful sexual intercourse. Nausea and vomiting can also be experienced. Since there are quite a few noticeable symptoms to remember with PID, you can use the acronym PITADS. PID is a clinical diagnosis. Critical criteria for PID include cervical motion tenderness, uterine tenderness, and annexal tenderness. PID can cause an abscess, as mentioned earlier, in the fallopian tube and ovary. This can turn into a tubal-ovarian abscess, or TOA, which can be life-threatening if it ruptures. Here we see a list of differential diagnosis of PID with their indicated features. We have appendicitis with right lower abdominal pain, loss of appetite, cystitis with strong persistent urge to urinate and/or dysuria, ectopic pregnancy with a positive pregnancy test, endometriosis with chronic pain, no history of STD, gastroenteritis with sudden onset of loose, watery stool, irritable bowel syndrome with generalized abdominal pain, including constipation and/or diarrhea, ovarian torsion with acute severe unilateral pelvic pain and vomiting, ovarian cyst rupture with unilateral sudden onset of severe pain, and tubal ovarian abscess, in which a patient will come in looking very sick and have severe unilateral pain. There is no specific test for PID, but there are some that can support the diagnosis. If PID is not diagnosed, the complications can be very problematic for the woman. Key components of a physical exam include a pregnancy test, which can rule out ectopic pregnancy if the test comes back negative, a pelvic exam that checks tenderness and swelling in pelvic region, This exam can include a microscopic evaluation of the cervical vaginal discharge for signs of infection, doing a nucleic acid amplification test, which is part of HIV screening that can be used to identify bacteria such as C. trachomatis, N. gonorrhoeae, and M. genitalium, and an ultrasound which creates images of reproductive organs using sound waves. Additional tests include laparoscopy, where a thin, lightened instrument is inserted through a small incision to view pelvic organs, and an endometrial biopsy, where a thin tube is inserted into the uterus to remove a small sample of endometrial tissue. This tissue is then tested for signs of infection and inflammation. Although gonorrhea and chlamydia are the main pathogens in PID, the disease is actually polymicrobial in origin, and therefore treatment involves giving a mix of antibiotics to treat the bacterial infection. Para-internal therapy involves an injection of cefotatin or cefoxitin, followed by 14 days of oral dioxycycline to treat the bacterial infection. Management of partner or partners can help prevent reinfection with an STI, and temporary absence can help complete treatment. Surgery, although rare, can be performed only when an abscess is present in order to drain it. Please remember to practice safe sex and get tested. Thank you.